Hi, my name's Mark Taylor. I'm a credentialed diabetes educator with Diabetes New South Wales. Diabetes New South Wales is a charity-based organisation providing education, support and advocacy for people living with and at the risk of developing diabetes. The aim of the session is to increase teachers' knowledge in regards to type 1 diabetes in a school setting, with specific emphasis on management of students with type 1 diabetes to enable the school to provide a safe and effective learning environment for all students with diabetes. I will discuss the two main types of diabetes, clarifying any perceived misconceptions, then go on to discuss the causes, symptoms and treatments of hypoglycemia or low blood glucose levels, one of the most common and potentially serious acute complications of insulin therapy. I will also discuss hyperglycemia or high blood glucose levels, along with special considerations, safety aspects, rights and responsibilities of all parties involved in care of a student with diabetes, and will conclude with a guide to some relevant resources that can assist you in supporting a student with diabetes. What is diabetes? Diabetes is a condition where the blood glucose level, or sugar level, is higher than normal. Diabetes means high glucose levels, commonly referred to as sugar, in the blood caused by a lack of insulin production or ineffective action of insulin or a combination of both. To understand diabetes, it is important to understand what happens to the digestion of food in people with diabetes. Following a meal containing carbohydrate food, the blood glucose level rises, peaking around 1 hour and drops back to normal levels after 2 hours. Carbohydrates are contained in all starchy and sugary-based foods. In response to an increase in the blood glucose level, the pancreas produces insulin. Insulin is a hormone that is necessary to move glucose from the bloodstream into the cells. Insulin acts like a key, unlocking the doors to the cell, allowing the glucose to enter. Glucose in the cell is converted to energy. This is the main fuel for our body. Glucose is also stored in the liver and released back into the bloodstream during times of prolonged fasting, such as overnight, preventing blood glucose levels from falling too low. If there is no insulin or insufficient insulin, the glucose remains in the bloodstream. High blood glucose levels can cause short and long-term complications. There is currently no cure for diabetes, but there is hope through promising research, particularly into type 1 diabetes. Although challenging at times, diabetes can be managed. There are two main types of diabetes, which are quite different in their cause and management. I will explain each in more detail to clarify some common misconceptions about the two main types. Type 2 diabetes is the most common form of diabetes, making up 85% of cases. Risk factors associated with type 2 diabetes are often related to lifestyle, such as poor eating habits, lack of physical activity, and carrying extra weight. These factors contribute to a condition known as insulin resistance, where the body is unable to use insulin effectively. Type 2 diabetes is more common in older adults, however, it is becoming more common in younger adult and children due to lifestyle and genetic factors. Type 2 diabetes usually has a slow onset with few or no signs and symptoms and is commonly diagnosed by routine blood test. It is estimated that for every person diagnosed, another person is undiagnosed. Type 2 diabetes is managed with lifestyle modification. It may also require the use of medication, be it tablets or insulin injections, to treat the diabetes. Commencing insulin therapy in a person with type 2 diabetes does not change the diagnosis to type 1, a common misclassification. The person still has type 2 diabetes, but is now insulin requiring. Type 1 diabetes differs from type 2 in many ways. One of the main ways is the fact that type 1 diabetes is an autoimmune condition. This condition is triggered by an environmental factor resulting in the immune system turning on itself and destroying the insulin-producing cells in the pancreas. This leads to a total lack of insulin production. It is not fully understood what triggers the immune system to turn on itself, but viral infections, trauma, and other stress factors are thought to play a significant role. Research into prevention of type 1 diabetes is ongoing. Type 1 diabetes can be genetic, however, often occurs with no family history. Studies on identical twins have shown that if one twin has type 1 diabetes, the other twin has approximately a 40 to 50% chance of developing it. I'd like to emphasize that type 1 diabetes is not caused by poor lifestyle and can't be prevented. A lack of public awareness amongst children has at times resulted in those with type 1 diabetes being unjustly teased or bullied and blamed for having eaten too much sugar or junk food. Type 1 diabetes occurs most commonly in children and young adults. However, it can occur at an older age. It is often associated with celiac disease, which is another autoimmune condition. Usually, there is a rapid onset with significant signs and symptoms of extreme thirst and frequent urination, lethargy, blurred vision, and excessive and often rapid weight loss. The management of type 1 diabetes involves the replacement of naturally produced insulin with injected or pumped insulin. This may require the person to have up to 4 or 5 injections a day or receive continuous supply of insulin via a device called an insulin pump. Without insulin, a person with type 1 diabetes can become unwell very rapidly and can progress to a life-threatening condition called ketoacidosis, a state of severe metabolic imbalance. Students with type 1 diabetes need to balance the injected insulin with regular carbohydrate intake to avoid high and low blood glucose levels, which can be challenging at times. It is important that students test blood glucose levels frequently as means of knowing where their blood glucose levels are. It is often impossible to know what levels are by how a person feels. Most students are recommended to test between 4 and 8 times a day. It is essential that the student has direct access to his or her testing kit at all times and should be able to test in the classroom. Walking to the office to test may cause a low level to drop even lower. Testing in the classroom also helps to demystify diabetes for other students. Following a diagnosis of type 1 diabetes, young people are often started on insulin injections, usually a combination of multiple injections of rapid-acting insulin at mealtimes and a once to twice a day injection regime of long-acting insulin as a background. Later on, children may change to an insulin pump. Insulin pumps are computerized devices that are worn continuously, except for showering and contact sports. The pump delivers a 24-hour background of basal insulin, individually programmed for each student. Every time the student eats or drinks carbohydrate food, the amount needs to be entered into the pump. If the blood glucose level is checked, the reading also needs to be entered. The pump will then calculate how much rapid-acting insulin, or also referred to as a bolus, is required to maintain the blood glucose level in target range. The benefits of a pump are that it provides more flexibility with meals in terms of timing and quantity of carbohydrate food consumed and alleviates the need for multiple injections. Other benefits of the pump are that it has shown to reduce the risk of hypoglycemia or low blood glucose levels, in particularly overnight, and improve overall blood glucose level control. The tubing and cannula usually inserted in the stomach or upper buttock in younger children needs to be changed approximately every 3 days to avoid infections. Disadvantage of an insulin pump can be accidental disconnection or dislodgement can occur, posing an immediate risk of elevated blood glucose levels within a few hours, as the infused insulin runs out. Without active insulin, students can deteriorate rapidly, developing a potentially life-threatening condition called ketoacidosis. Maintaining blood glucose level on target can be a real balancing act. Many students will be asked to maintain their blood glucose levels somewhere around the range of between 5 and 10 millimoles per litre. Many factors can affect blood glucose levels. Injected insulin and physical activity lower blood glucose level and need to be balanced with the right amount of carbohydrate food. It is important that the student eats all the food that the parents prepare for them. Smaller children may need to be supervised to ensure they have eaten all their required carbohydrate food to prevent their blood glucose level from dropping too low. Stress hormones and hormonal changes during puberty, on the other hand, usually raise blood glucose levels. Any stress caused by physical or emotional responses, for example anxiety or excitement, pain or illness, can trigger a stress hormone release, including adrenaline. Stress hormones slow down the action of insulin and raise blood glucose levels. Growth and development, particularly in puberty, can also result in unstable blood glucose levels due to hormonal changes. Hence, insulin doses may need to be adjusted regularly by the hospital team, usually by an endocrinologist or a credentialed diabetes educator. Hypoglycemia. Hypoglycemia, or commonly referred to as a hypo, is a common side effect for anyone on insulin. Hypoglycemia is usually classified as a blood glucose level under 4 millimoles per litre. Symptoms vary from student to student. Young children, such as children under 5 or 6, are often not able to recognise and express symptoms. They may complain of a funny tummy, wobbly legs, or feeling unwell. Older students may express one or more of the listed signs and symptoms, such as feeling shaky, sweaty, teary, or irritable, or generally exhibit unusual behaviour. These signs and symptoms should be followed up by a finger prick blood glucose test, if possible, and treated immediately. As blood glucose levels can quickly deteriorate and the student can become disorientated, agitated, and may refuse treatment, become non-responsive, and eventually potentially unconscious. It is essential that the school is provided with an individual healthcare plan that clearly describes the child's symptoms and treatment of mild and severe hypoglycemia. Common causes of hypoglycemia can include changes to meal times or changes to the carbohydrate intake at the meal. If the student swaps or misses recess or lunch or doesn't eat at all the carbohydrate part of the recess lunch, this will increase the risk of hypoglycemia. Parents of smaller children may label the food the child should eat for each meal. During and after sport or unplanned or prolonged physical activity or play, the student will be at higher risk of a hypo. This is due to the cells burning up more energy, hence using more glucose, as well as physical activity causing improved insulin action or insulin sensitivity. This glucose lowering effect can last up to 12 or more hours, depending on the duration and intensity of the physical activity. Hence, the student will need to be monitored for hypos during the night. Too much insulin injected due to error or change of requirements can also cause a hypo. Unfortunately, and to the frustration of students and parents, a hypo can be unpredictable and occur for no obvious reason. Treatment of a mild hypo. For students on injections of insulin, if their blood glucose level falls to below 4 millimoles per litre, we recommend a two-step approach to treating their hypo. A hypo should be treated immediately with a quick-acting carbohydrate, such as 1 pop of fruit juice, or 2 to 3 teaspoons of sugar or honey, or half a can of soft drink, or whatever is stated in the student's healthcare plan. Blood glucose levels should be checked before treating a hypo, if possible, and again 10 minutes after the immediate treatment. If the blood glucose level is still below 4 or symptoms persist, repeat step 1. It is crucial that the treating staff ensures that the full treatment is consumed by the student, even if they may refuse. During a hypoglycemic state, a student may not behave rational and may need to encourage to drink the juice. Following step 1, a slower absorbed carbohydrate should be consumed, which could be 1 packet of Tiny Teddies, or half a sandwich, half a glass of milk, or 1 to 2 pieces of fruit. If the student is on an insulin pump, they don't always need to follow step 2. No insulin should be administered through the pump for the quick-acting hypo treatment. This should be clearly explained in the child's healthcare plan. It is the parent's responsibility to provide adequate hypo kits and keep them stocked up. However, the school needs to let the parents know when a hypo kit has been used. It is recommended that a few hypo kits are available in different locations, such as the student's classroom, the office, the library, or the playground, depending on the size of the school. Parents should advise school staff if there are any changes to hypo treatment. It is important for the blood glucose meter and hypo treatment to be wherever the child is, and to monitor and treat a hypoglycemic episode in the classroom and not send the student to the office for treatment. Blood glucose levels can drop rapidly and the student could pass out on the way. The most important key message about recognising and treating hypoglycemia in a school setting are to act immediately if you are uncertain about the symptoms and whether they are related to a hypo or a high BGL. Treat as a hypo and administer juice or another form of sugar as per the healthcare plan. Due to a lack of glucose supply to the brain, the students may be uncooperative and refuse treatment. It is essential that the teacher and staff encourage the student to take their treatment. If a blood glucose level meter is in reach, check the blood glucose level, otherwise treat as a hypo and never leave the student unattended during a hypo until they have fully recovered. Managing severe hypoglycemia. In the rare event of a severe hypoglycemic attack, where the child may become semi or unconscious, please provide general first aid. Place the student in a recovery position, maintain the airway, and do not give anything by mouth, not even honey under the tongue. Call an ambulance via 000 and state diabetes emergency, and then call family members. There is an option of an emergency treatment called glucagon, as seen on this slide. However, glucagon should only be administered by a family member or a paramedic or a trained staff member. Under certain circumstances, such as if the student attends a remote school where an ambulance is more than 20 to 30 minutes away, or if the student attends a school camp, school staff may volunteer to be trained. Recognising hypoglycemia. Hypoglycemia is when a blood glucose level is over 15 millimoles per litre. It is another potential acute complication that a student with type 1 can experience. Symptoms can be similar to that of a hypo and are sometimes difficult to distinguish unless a blood glucose test is performed. Symptoms can vary from child to child, but typically they include thirst and frequent urination, tiredness or disinterest, difficulty concentrating and completing tasks, hunger or reduced appetite, or the student may exhibit unusual behaviour. Common causes of hypoglycemia include if the student eats extra carbohydrate food, maybe through swapping food or buying extra at the canteen. Although it should be noted that most students are aware and conscientious about the importance of portion-controlled carbohydrate intake. A spurt of vigorous exercise could temporarily cause a spike in blood glucose levels, but this usually falls again within a couple of hours. This is due to the body's hormonal response that results in adrenaline and other stress hormones being produced and counteracting the blood glucose lowering effect of insulin. Similar responses can occur if the student experiences anxiety, excitement, or other emotional stress. However, the most concerning reason for high blood glucose levels are illness and infection, and these can raise blood glucose levels very acutely and, if not treated, can deteriorate to a potential life-threatening condition called ketoacidosis. Similarly concerning would be if the student misses an insulin injection. For students wearing an insulin pump, the tubing can become dislodged or kinked, which could result in missing vital insulin delivery. Managing hypoglycemia. It is extremely important in the child's action plan that it is documented how to treat or manage a hypoglycemic episode. Generally, the management states that if blood glucose levels are above 15 millimoles per litre, to contact parents for treatment advice. Parents may advise to check for blood ketones, which is performed with the same meter that is used to test blood glucose levels. Depending on the student's age and the individual's agreement, this is done by the parent, school staff, or the student themselves. The presence of blood ketones is a sign of a metabolic imbalance and is an indication that treatment is required immediately. Additional blood glucose testing as per healthcare plan should be performed if the blood glucose level is above 15. If the student is well, no action may be needed except for follow-up blood glucose testing to observe the trend of the blood glucose levels. However, if the student is unwell, he or she needs parental care at home. As a general guide, if the blood glucose level is above 15 and the student is well, he or she should be encouraged to drink extra unsweetened fluids, be allowed to have more frequent toilet visits, and should refrain from physical activity such as running around or other energetic activities. Special considerations. Any student with type 1 diabetes should not be excluded from any activity that all other students are doing. The key to success is to plan ahead and ensure timely communication with parents. Classroom parties, school camps and excursions. It is important to discuss with parents if the student is allowed to have party food or permit the parents to bring in an alternative food. School camps can be a challenge for students with diabetes and their routine. Their blood glucose levels may be more unstable, hence it is important to discuss activities, food and requirements well in advance. Due to excitement, extra physical activity and possible change in timing and change in the food intake, a student with type 1 diabetes may have an increased risk of high and low blood glucose levels while at camp. However, this risk can be minimised with careful planning. The healthcare team may need to provide input to the planning, especially for insulin requirements and adjustments. Depending on the student's age and independence, a parent may accompany the child. As with camps, sports days and excursions require additional blood glucose testing and adequate planning and communication with parents well in advance, as a change in insulin dose and/or additional carbohydrates may be needed. Again, it may be preferable that a parent attends for younger students. For student detention, it is imperative that blood glucose testing equipment and additional food are in reach of the student. and never leave a student unattended. Food should never be withheld. When sitting exams, the student may need special provision and the Board of Studies will need to be notified well in advance. The student should be allowed to have access to food and drink and may need extra time for testing. Out of control blood glucose levels during an exam can negatively affect cognitive function and test results, in which case a misadventure form may be required. Special considerations. It is extremely important that all staff members, including any relief staff, know which children at school have type 1 diabetes and know where to access the information for them. A medical alert form with the student's picture and medical emergency information should be made available to all staff. Relief teachers and all school staff should be made aware of where to locate the healthcare plan, the hypo treatment kits, and be informed how to recognise and treat hypoglycemia, and be explained the reasons why a student with diabetes must never be left unattended if unwell. They should also be informed where to obtain further information. More information. For further information, please contact Diabetes New South Wales via our customer care line on 1300 136 588. Please ask to speak to a diabetes educator for any further information you would like in regards to type 1 diabetes in a school setting. Diabetes New South Wales has produced a number of practical resources, including our school pack and booklets for parents and students. The school pack contains a flip chart with succinct information on topics discussed during this presentation, a diabetes emergency information poster, fact sheets on type 1 diabetes, physical activity and hypoglycemia, duty of care, a note for parents, and templates for a medical alert and healthcare plan. A DVD titled Professor Bumblebee's Guide to Type 1 Diabetes has been very popular as an educational and entertaining guide to help other students understand more about diabetes and prevent potential teasing of students with type 1 diabetes. You can order our school pack and other resources by calling our customer care line on 1300 136 588. Infection control and safety considerations. Where insulin injection occurs during a school day, it is important to look at having correct storage of insulin and also safe disposal of sharps. Where possible, no sharps should be handled at school, but instead sent home each evening for removal and disposal. Good communication with parents is essential for achieving amicable care agreements. A written communication booklet should be considered to assist the managed care and avoid miscommunication. It is important that all other students should be aware that the person's finger pricker and insulin delivery devices are not to be touched by them. Rights and responsibilities. It is recommended that the rights and responsibilities for all parties are clearly defined. Clarification of rights and responsibilities should be communicated to avoid misunderstandings and create a safe environment for the student. Parents are responsible for informing the school about the diagnosis of diabetes and providing an individualised healthcare plan. It is also the parent's responsibility to ensure all hypo packs, blood glucose equipment, and medication is available at all times. The principal needs to ensure relevant diabetes management training for teachers and staff, including relief staff, and ensure that the healthcare plan is kept up to date. All teachers and staff are responsible to provide a safe learning environment for the student with diabetes. In particular, the classroom teacher should become familiar and adhere to the student's individual healthcare and emergency care plan. Supervise and record information when necessary, recognise the signs and symptoms of hypoglycemia, and act promptly at all times. Further information on the rights and responsibilities of the student with diabetes can be found on the New South Wales Department of Education and Community Services website. The key to successful diabetes management is ongoing communication amongst all parties. Diabetes and learning. The level of support required from staff to students with type 1 diabetes will depend on the age of the student. Not only the age, but also the level of independence and family involvement. Students with diabetes like to be treated as equal, so expect and demand the same, but remember that they may rely on your support, particularly at times when their blood glucose level drops too low and they may not be able to treat themselves appropriately or in a timely manner. Continuous communication between parents and school staff, either verbal or written, is the key to optimal diabetes management during school hours.